Namaste, my name is Alberto Valle and his name is Alberto Zanini. We are both from Italy, we are obstetrician and gynecologists. We came here to Pokhara on behalf of ANT, which is an Italian NGO, which means Amici della Neonatologia Argentina, because we run some courses in the Pokhara region about obstetric and level 1 emergency. We are using Australian mannequins and dolls just to show the practical training, and we hope that since the mannequins will remain here in Nepal, other people will use those and increase their practical skills. Thank you. This is breech delivery. When you deliver a breech, just remember always to keep the back of the baby upwards and ask the patient to push only when the breech is visible at the perineum. When the breech starts distending the perineum, that's the time to perform an episiotomy. Usually the legs comes out on their own with efforts of the mother, and then you wait until you see the tip of the scapula, and as you will see in a few seconds. Now that's the tip of the scapula when you can start thinking to do a Lausitz maneuver. You grasp the bones of the baby, the sacrum, and you turn the baby laterally and downwards 180 degrees. You deliver the first arm and then the second one doing the same maneuver on the other way. In this way you deliver both arms with the Lausitz maneuver. Then you wait for the following contraction, and when you see the nape of the neck, that's the time to deliver the head of the baby. With the Morisot maneuver, you put the middle finger of your right hand in the mouth of the baby and the medium finger of the left hand on the occiput of the baby, and then you make a traction upwards. That's delivery of the baby. Some people prefer to deliver the after coming ahead in a breech delivery with the forceps because they feel that the traction is less traumatic. So in this case, you just ask your assistant to bring up the baby. You take the blades of the forceps and you insert, as usual, the left blade into the vagina. You keep down the perineum and you go directly on the head of the baby. You do the same with the right blade, and as usual you put a towel between the blades, and you keep down the perineum with the right hand, or the other way around, depends if you're left-handed or right-handed, and then using just the force of your forearm, you just deliver very gently the baby's head like this, in this way. Shoulder dystocia. If the McRoberts maneuver fails, you should start first with the easiest maneuver, which is called Rubin 1. In this case, you need always to know where is the back of the baby. With the Rubin arm maneuver, you just press over the abdomen of the lady, trying to put the anterior-posterior shoulders in an oblique situation. Rubin arm maneuver. As we said before, the first thing you have to check where is the back of the baby. Then you look for the symphysis pubis of the woman. You put your both hands like in CRP and you just press downwards and laterally in order to put the shoulders on an oblique diameter, as you can see. This is the maneuver is called Rubin 2. Is the first of an intravaginal maneuver. You just put two fingers on the posterior aspect of the anterior shoulder and then press on the shoulders to put the shoulders on oblique diameter. As we said before, you just put two fingers on the posterior aspect of the anterior shoulders and then you press laterally, and as you can see, the head moves and the shoulders as well. This is the Woods maneuver. So you put the fingers on the posterior aspect of the anterior shoulders, but you add the force of the two fingers posteriorly on the anterior aspect of the posterior shoulders. In this way you rotate the baby 180 degrees, and now we will show that intravaginally. If none of the previous maneuvers had succeed, you have to try to extract the posterior arm of the baby. So you put all your hands in the vagina, you try to find the arm of the baby, you just press the elbow and you pass the forearm of the baby just in front of the thorax, and then you extract the arm. Extractor, introduced by Professor Alberto Valle from Brisbane. And anyway, before doing any instrumental delivery, you always be sure about the position of the head inside the pelvis. So the first thing is to find out the longitudinal suture, and then going ahead and backwards you find the fontanelles, the small fontanelle behind, and in front, 3 centimeters in front of the small fontanelle, that's the flexion point where the vacuum should go exactly like this. This is the kiwi, and you can see on the traction tube there are 2 marks, one at 6 centimeters and the other one at 11 centimeters from the cup. So you usually use the 6 centimeter mark for occipital anterior position and the 11 centimeters mark for the occipital posterior position. This is the application of the kiwi in occipital anterior position. You just pull the cup inside, and then you push the cup until you reach the 6 centimeter point. Then you make the vacuum. Then you put your 2 fingers just as counter pressure on the fetal head and you pull down easily. and then there is a contraction end, so just relax, and then when the contraction start again, you pull downwards and then at the end upwards, and you deliver the baby's head. As you can see, the cup is exactly on the flexion point. The application of the cup on a posterior position, the procedure is the same. The difference is that you have to push the cup until you reach the 11 centimeters mark, which has been reached now, as you can see. So you keep the cup attached to the fetal head and you make the vacuum, and when you reach the right pressure you will start pulling downwards, much more downwards than occipit anterior position, always during the OP deliveries. You do the usual counter pressure on the fetal head. The head is coming, but you need another contraction, and then there is another contraction, and so that you can pull out the baby's head like this. In the meantime, the head will rotate inside the pelvis. Now, forceps deliveries has been abandoned in many countries, but is still a valuable tool as long as you apply just only when there is an occipit anterior or occipital posterior position, not rotational forceps, but just. The forceps is composed by two blades. This is, you start always with the left blade. You just put your fingers between the fetal head and the vaginal wall of the woman, and then you insert the blade very gently using your thumb to just get the right direction, and then you take the second blade, which is the right one, and you do the same on the other side. Just look at the finger, the thumb, which is very important to give the direction, and then you make the articulation of the forceps downwards. You put a towel between the blades as usual in order to avoid to squeeze too much the fetal head, and then you will, just using one arm, you just deliver the baby, which is here in this OA position. And if possible, you just take the forceps out before the head is completely out, like in this case. V-Lynch suture. With V-Lynch suture you have to use a long needle, curved needle. You start putting your needle 3 centimeters below the cesarean section incision. Then you secure the thread at the end, just to be sure not to lose it. Then you go 3 centimeters above the cesarean section incision, as you can see. Then you go with your needle posteriorly, and you take a big bite of the myometrium just between the two uterosacral ligaments, and afterwards you go again anteriorly 3 centimeters above the cesarean section incision and 3 centimeters below it, with the assistant who is squeezing a little bit the uterus. Okay, and this stage, before doing the knot, you have to close first the cesarean section incision, and then you squeeze the uterus and you make the knot in this way. So at the end the uterus is like this. This is the hymen suture. You need a long straight needle. You don't need a cesarean section incision. It's very simple. You just go from front and backwards of the uterus, as you can see, and the assistant keep the thread, and so you get another needle on the other side. The other side, as you can see, hymen suture is probably simpler than a B-linge suture, because it's just a question to put the stitches from one side to the other side of the uterus. So the second stitch has been applied, and then the assistant squeeze the uterus as in the B-linge, and the surgeon make the knots in either side, as you can see. And the result is more or less the same as in the B-linge suture.